Hi, my name's Glory. I'm one of the new attendings here at Weiler.
Now, Weiler.
So this morning we're just going to talk a little bit about evaluating the pediatric C-spine in blunt trauma. Where do you guys do most of your peds training? Do you see peds at Jacoby?
Yes.
That's where you get most of your peds? Okay. Oh, in Monty. All right. And has anyone had like an actual pediatric patient with an actual C-spine injury?
No.
Anyone see her? Okay. So they're pretty rare. And at Monty and Jacoby, does trauma have like a protocol for evaluating or clearing the C-spine? Like, is there like a set pathway that you guys follow each time? No. I only asked because I did most of my peds training at CHOP in Philadelphia, and they have a lot of pathways for patients who come in. So they have like a pathway for people, trauma patients who come in for evaluating like the head, like when to image and when not to image. But they don't have one for C-spine. So I was just wondering at these places, is there a pathway or an agreed upon protocol for evaluating a C-spine? But it sounds like no. Okay. So like most things in medicine, this is an art. And I say it's an art because, like I was just saying, there is no gold standard or standard of care for evaluating the C-spine. So hopefully this morning with the information that I present to you, you can sort of use this the next time that you have a blunt trauma patient to sort of figure out how you want to go about clearing the C-spine. So those are my objectives. I'm sorry if you guys can't. Can you guys see that? All right, sorry. Yeah. Why? Do you want to try the big screen? No. That's not working?
Big screen, we want the big screen.
The bulb is going to keep shining out every 10 seconds.
Oh, okay. All right. So I actually trained at Jefferson in Philadelphia, and one of our big name attendings is Judd Hollander. And if you don't know that name, you'll get to know him. That name is during your career in emergency medicine because he's well known for his work in chest pain and risk stratifying low risk chest pain. And everyone was really excited when we got him because we stole him from Penn. And he actually trained here at Jacoby like many moons ago, but he was always very proud and always spoke very highly of the residency program and the training he received here and just like the residents and the quality in general. But he's a real character, and if you ever get the chance to meet him, please don't tell him that I said that because he's a really well-known, like powerful person. Not the kind of person that you want to piss off, but he was always one of my favorite attendings in residency because he always just sort of like went for it. Why some of the other attendings would sort of like shy away from doing certain things or sort of like drag their feet, he would just go for it. So I remember once we had this patient, she was like a 85-year-old grandma. She had like a trip and fall, and she came in, she had like an obvious ankle fracture, and like as EMS is rolling her into the room, he's like, all right, put it back in. And I'm like, okay, well, are we gonna like get an x-ray, or are we gonna, you know, do a hematoma block, get an IV, like do sedation? And he's like, no, just put it back in. So I don't know, like after that experience, I was like, what the hell do they do at Jacoby? But but you guys are, you know, you're big city hospital, you see tons of patients, but yeah, he's a character. But anyway, so these are my objectives. We're gonna start off by talking a little bit about the anatomy. So one of the most important things to think about when you're evaluating the C-spine is just the differences between adult and pediatric C-spines. Well, actually, no. First, let's start with epidemiology. So first, they're pretty rare. No one in this room has seen them. In blunt trauma, they're about less than 1% of all injuries. In your kids that are less than 8 years old, usually the injuries are higher up. So your occiput down to your C2. And anything that you see in red, I'm currently studying for the boards. So things that have come up, I've sort of tried to highlight in red, just so you guys can keep in mind. If you see a patient after trauma with torticollis, make sure you think about allano-axial displacement. And then in your kids that are older than 8 years old, you're going to have more lower C-spine fractures. And those are just like the most common mechanisms, MVCs and falls. Sports injuries once kids get a little bit older, like older than 8. So the pediatric C-spine is currently developing at about age 8 is when the C-spine resembles more so an adult C-spine. But younger than that, there are certain things like to keep in consideration. So we all know that kids, especially when they're young, they have really big heads compared to their torso. So their sort of like axis or fulcrum is a little higher, and that's why they tend to have higher C-spine injuries like C1, C2. Also, their ligamentous support and their muscular support is just not as well developed as it is in adults. So that also predisposes them to C-spine injuries. But then as you get older, in older kids, they're more likely to have injuries associated with fractures, as opposed to younger kids. They can have injuries without any fractures because things are sort of just so loose because the ligaments and the muscles aren't so well developed that their spine can actually move, and they'll have some sort of like contusion or vascular injuries without any fractures on their radiographs. And then also in pediatric patients, their vertebrae is incompletely ossified. And then in red, just something to know, for whatever reason on the boards, they want you to know that odontoid fractures are the most common pediatric C-spine fractures. So who should you immobilize? These are just, it's mostly based on mechanism. And so you'll see them listed there, people who have like distracting injuries. If they're altered, obviously you want to immobilize them. If you see any injuries above the clavicle, if it's a multi-trauma to other places. And then also fall from height. This one was a little tricky. I looked and I searched for what height is considered a dangerous mechanism. And so some places said if it's greater than the patient's body height, that's a dangerous mechanism. If you think about the PCAR and CT head rules, if they're less than 2, a height greater than 3 feet is considered a dangerous mechanism, and if they're greater than 5 feet. And then there's also the Canadian C-spine rules, but they only evaluated patients who were greater than 16. And there they say greater than 3 feet is considered a dangerous mechanism. And then also think about kids that are maybe predisposed to having C-spine injuries. One of them, if you remember your trisomy 21, they're predisposed to alaxio-antral instability. So you guys remember that from like med school. And then when you immobilize them, it's a little bit different from immobilizing adults. If you see those 2 pictures there, if you just use a standard backboard, because their occiput is so much bigger than their torso, they won't be in neutral position. If you see in that top picture there, I hope you guys can see it, as opposed to the bottom picture where they have sort of like a sheet rolled under them, or sometimes they'll put a roll underneath the neck so that the neck is in a more neutral position. Okay, so we're going to talk a little bit about Nexus, because we all know and love Nexus. We use it every day for our patients our adult patients that we see. And it's been well validated. And it was a prospective observational study. They had over 34,000 patients. It was nationwide, 21 EDs. And using this criteria and classifying patients as low risk, had a 99% sensitivity. So after the Nexus study was validated, they didn't have a lot of pediatric patients, but they took the population of pediatric patients that were involved in the study, and they tried to figure out what the sensitivity would be just looking at those patients. And this was published in 2001 in the Journal of Pediatrics. So Out of all the Nexus patients, a little over 3,000 of them were younger than 18. So it was about 9% of the study. They only had 30 pediatric patients that had a serious cervical spine injury. So about 1%, like what was quoted earlier. And of these patients, using the Nexus criteria, they had a 100% sensitivity and wouldn't have missed any of the patients. But as you can see, it has a pretty wide confidence interval. And part of the reason for that is because it was a small sample of patients who actually had, traumatic injuries. So it was pretty underpowered, and they couldn't definitively say that this criteria could be used to, rule out C-spine injuries in pediatric patients. And of note, tenderness and distracting injuries were two of the most common features in patients who had traumatic injuries and patients who did not. And they didn't find any injuries in patients under 2, because it's even more rare. And then in 2008, this is a retrospective study that came out in the Journal of Neurosurgery. Single center study, over a 20-year period, they looked at 190 children who had C-spine injuries, and they applied Nexus to them. And so in the patients who were less than 8 years old, they had a very small N. It was only 34 patients, but it was 94% sensitive. And then the patients who were older than 8, it was 100% sensitive. Which, if you think about what I said earlier, how at about age 8, the pediatric C-spine starts to more resemble an adult C-spine. So applying Nexus to those patients had 100% sensitivity. Now I put this here because most of the reading that I did from different societies, whether it was trauma or neurosurgery, everyone sort of does like a combination of using the Nexus criteria, keeping in mind the fact that it hasn't been validated for pediatric patients, and it's not as sensitive, especially when you get to that less than 8 years old. They still use it, and then plus or minus some sort of imaging. But then in infants, for most of the reading that I did, especially if it's minor trauma, it's really just like a clinical evaluation, especially if there was no loss of consciousness, there's no neurological deficits, and there's no distracting injuries. You take off the C-collar and you sort of observe them, watch them move their neck around, make sure they don't have pain, if they're like acting normally, and you have like a normal neurological exam for that age group. They sort of clinically clear themselves, if you will. And also, it's when you get to this age group, having a C-spine injury is also pretty rare. So let's say you have a patient, you use the Nexus, maybe they don't quite meet, maybe because they have tenderness, and you decide you're going to do some imaging. These are just some imaging recommendations based on age. Most places, like I said, CHOP, like their pathway, they will start with plain films. So usually it's AP lateral of the neck, odontoid view if they are greater than 5, not if they're like less than 5. And then also consider that in the very young kids, since they tend to have pretty high up C-spine fractures, if you're using PCARN and you're going to scan their head anyway, they usually in CT scans will capture like C1, C2, even down to C3, so they may not need additional imaging. So we're going to just talk a little bit about radiographs. Most of us will probably mostly see adults, and so when you have a pediatric patient that you're concerned about a C-spine fracture, I think most of us will probably just go straight to CT or maybe even MRI. But I think it's important to at least be familiar with the radiographs. So like I said, odontoid if they're greater than 5, and then AP lateral. So this is an odontoid view. And the things that you're sort of checking for. Is it working? Oh, it's not working. Okay. Oh, maybe I can do this. Do you see a mouse? All right, so this view, you're looking at the lateral masses of C1, and then this is C2. Here's the dens. And you're basically evaluating the distance between the lateral masses and the peg of the dens. And then you also want to check and to make sure that there's alignment here between the lateral masses and the body of C2 and here. So you can see here there's some malalignment here, and this isn't even. So in this person, you would be concerned for maybe like some sort of Jefferson fracture of C1. But you can get false positives if the head is rotated. And so then this is the lateral, and for it to be adequate, you have to be able to see all the way down to C2. And so these lines just represent the sort of lines that you want to go down to look for any like malalignment. So you have your anterior vertebral line, the posterior, the spinal laminar, and then the posterior spinal. And then this is in red because this will, I've been seeing this a lot while studying for my boards, just the pre-vertebral spaces. So if the pre-vertebral spaces are widened, that can be a clue that there might be an injury, because they might be widened because of like swelling and edema, if there's like a ligamentous injury there. So remember at C2 it's 6 millimeters, and then at C6 it's 14, and then at 22 millimeters for adults. And then you have your AP view. Okay, so just some things of note when looking at these radiographs. So like I said, the vertebrae are incompletely ossified, and they also, sometimes you can, I don't know, how do I want to word this? It can look like you have anterior like wedge fracture because of the way that the vertebrae ossify as the patients age, because they go from posterior to anterior, so it can look more dense in the posterior region, and it might actually look like you have a wedge fracture when you actually don't. You can get some pseudo widening in the prevertebral space depending on if the patient was expiring or inspiring during the time that they shot the x-ray, because remember, these are kids and you can't tell them, you know, when to expire. So you can't always use the whole 6 millimeters at C2 or 14 millimeters at C6 to determine if it's actually wide or not, because it depends on if the kid was flexed or extended, or if they were expiring at the time that the film was shot. And then you can also get something called pseudo subluxation, where it looks like C2 is subluxing on C3. And it could be normal, but it also could be a sign of a Hangmans fracture. And so you can do this thing that's called a Schwitzguts line. I think I'm saying that right. And it's where you take basically your ruler and you start at the anterior edge of this spinous process of C1, and you draw a line from there to the anterior edge of the spinous process of C3. And then you look to see that this anterior edge is less than 2 millimeters from the line. And if it's less than 2 millimeters, then it's likely just pseudo subluxation. And if it's greater, then you should be concerned for something like a Hangman's fracture. But this next picture, just because it's within 2 millimeters does not mean that you don't have a Hangman's. And so if you look at the picture on your left, that patient has a Hangman's fracture of C2, but they're within the line. as compared to this one. And you guys see that, right? And this is in red because it's one of your unstable fractures that you have to know for the boards. And it's usually a hyperextension mechanism. And it's when you get fractures of the bilateral pedicles of your C2. And while we're here, I'll just go over the unstable C-spine fractures. So the Jefferson fracture is just a fracture to the anterior and posterior masses of your C1. And then the bilateral facet dislocations, odontoid type 1 and type 2. Do you guys know what type 1 is? What was that? Just the tip. Just the tip. Okay. And then also atlantoaxial dislocations or any fracture dislocation combo. And then, of course, the Hangman. And then a teardrop fracture, which is it's an avulsion fracture. Here, I'll just show you. So here's a teardrop fracture. It's like an avulsion fracture of the inferior anterior portion of the vertebral body. And you get retropulsion of this posterior part into the spinal canal. And this would be an example of a bilateral facet dislocation. Jefferson fracture, and then these are your odontoid fractures. Type 2 is the base, and then type 3 involves the vertebral body of C2. And then also have to mention about Kimura. So this is basically when you have neurological deficits without any radiographic evidence of injury. And radiographic here refers to X-ray or CT. And this is seen in about 15 to 38% of patients. And this is more common in pediatric patients, especially less than 9. And again, it has to do with the fact that they have immature ligaments and muscles, and so they're more prone to have shifting or moving of their spine without actually fracturing anything. So you may look at their radiographs and they may be negative, but they have some sort of like neurological deficits. With some sort of like myelopathy. And so they're usually due to some sort of like ligamentous injury or bulging, or maybe they were subluxed and then they reversed before they got to you. And they can also be like vascular injury. And so remember that your vertebral arteries enter in at C6 in about 7% of patients at C7. So if you have a transverse fracture, transverse process fracture, and a patient with like neurological deficits, but the CT head is negative, then you should be thinking like, could they have some sort of like vascular injury causing their symptoms? And also symptoms may not present for several days like after the initial injury. And the way you want to evaluate for this would be with an MRI. You look for soft tissue damage. Okay, so these are my take-home points. Remember that the pediatric C-spine starts to sort of resemble an adult C-spine around age 8. So younger than 8, you're thinking more high C-spine injuries. Remember, if you're scanning their head, you're probably going to capture C1, C2, C3, which is really what you care about because that's where most of the injuries will be in that population. So maybe you don't need dedicated C-spine CTs. And then in greater than 8, they're more likely to be lower C-spine. And the Nexus is actually useful in patients greater than 8 years old, although it is not validated in any pediatric patients, but it is helpful. And you can start with AP laterals of the neck if you get inadequate views, or obviously if they're abnormal, then you can go next to CT. And then if you're evaluating for Kimura, it's going to be with an MRI to look for soft tissue. Okay, and that is it. Thanks, guys.